Just a quick overview of the bilirubin metabolism. I'll also discuss a little bit about how it plays an important role in neonatal jaundice. So when the hemoglobin breaks down, when the RBCs are killed and the hemoglobin is released, it breaks down into heme and porphyrin components. The heme is the iron-containing part, and heme is acted on by heme oxygenase, and biliverdin is released. Biliverdin is a precursor of bilirubin, and by the action of biliverdin reductase, unconjugated bilirubin is formed. Bilirubin that is released is bound in albumin, and when the albumin is exceeded in the plasma, free bilirubin is circulating, which is a dangerous situation as it can easily cross the blood-brain barrier. The unconjugated bilirubin is then taken up by the liver, where the enzymes UDP glucuronate transferase acts on to cause conjugated bilirubin, which then gets excreted through the bile into the stool. So part of the conjugated bilirubin gets acted on in the intestines, and it may get reabsorbed. This may be one of the factors related to breast milk related prolonged jaundice, where this enzyme is active, beta-glucuronidase enzyme is active in the breast milk, so the conjugated bilirubin gets broken down in the stool and it gets absorbed back into the bloodstream. So the jaundice persists. This is a benign type of jaundice, and we will discuss that later as well. So for most neonates, hyperbilirubinemia is a benign postnatal transitional phenomenon. However, developmental red blood cell, hepatic and gastrointestinal immaturity results in an imbalance favoring the bilirubin production over clearance. So if you look at this again, normally it's just the senescent RBCs that break down. But as we know, the fetus has a high load of red blood cells because of the hypoxic in utero environment. And when the baby is born, when exposed to the oxygen in the environment, more red cells are destroyed in the reticuloendothelial system. So there is a higher release of this RBC breakdown products in the baby's blood. The baby's liver is immature. This is even more so in the premature babies. So the conjugation process is slower than normal. So more unconjugated bilirubin circulates. So combined with the increased production, this also leads to the increase in jaundice. The babies are born vaginally most of the time, and during the birth process, the babies have bruising in some cases. In the premature babies, this is more significant. Some babies may have cephalohematoma, which is a blood collection in the scalp coverings. All these may lead to, again, more red cell destruction and bilirubin production. As we know, in the first 3 to 4 days, the baby is relatively dehydrated because the breast milk production is on the lower side. So obviously dehydration increases the risk of jaundice as well, because the conjugation process needs energy, and dehydration leads to hemoconcentration, which relatively increases the unconjugated bilirubin in the blood.